This episode is supported by Provider Solutions and Development, the holistic career coaching experts with 20 years of experience. Recruitment had to change, so they took away quotas and started listening to clinicians. Find the place you're meant to be. Reach out to psdrecruit.org/curbsiders.
The Curbsiders have partnered with VCU Health Continuing Education to offer free continuing education credits for physicians and other healthcare professionals. Check out curbsiders.vcuhealth.org to create your free account and to start claiming CE credit.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Like Memorial Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Well, Paul, this has been quite a special episode. Talked about wilderness medicine and just a ton of great stuff in this one. Our guest was Dr. Tom DeLoughery. And Stuart's not here, Paul, but I think we did great. We had a wonderful guest co-host who we'll introduce in a second. Paul, but first, tell people, what is it that we do on this show? And can you remind me the meaning of life?
Sure. Well, I'm going to answer your last question first. So I think we go with 42 each time. And then as to what we are and what we do here, we are the Internal Medicine Podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. We also have a spectacular producer with us and returning guest, Dr. Avital Oglasser, who also recruited the other fantastic guest that we have for this show, Dr. DeLoughery, who's going to talk to us all about what to do if... DeLoughery, forgive me. Who's going to tell us what to do if we get bitten in the face by something mysterious or lose a limb falling down the mountain. So, Dr. Oglasser, Avital, please tell us more about our fantastic guest tonight.
Yeah, so I have the privilege of actually being a colleague at OHSU with Dr. DeLoughery. Tom is a native Hoosier who graduated from Indiana University School of Medicine. He did his residency in internal medicine and fellowship in Heme-Onc at Oregon Health and Science University in Portland, Oregon. And he is currently a professor of medicine, pathology, and pediatrics there. He has always had a strong interest in hematology and other aspects of wilderness medicine, which is clearly our focus tonight. He is a lifetime member of the Wilderness Medical Society and was on their board of directors for several years, as well as serving as the chair of their research committee and remains an active member. He's been awarded both research and founders awards by the Wilderness Medical Society, and across the board, Tom truly is the triple threat, dedicated clinician, educator, and researcher. He is aptly named @Bloodman on Twitter. And Tom teaches us, I kept dubbing this the Halloween episode that wasn't, for many ways, but we talked about coagulation. Of course, he's a hematologist. How can we avoid that? Venting insulin bottles, dexamethasone, and not in the context of COVID. Why sometimes it's just better to stay horizontal. Burritos and the DeLoughery Triangle of Doom.
Yeah, and snake bites. It's packed. It's really great. All right. Tom, thank you for joining us. This is a much needed topic right now. First, though, we're going to ask you, tell us a little bit about yourself. Tell us some hobbies that you have, some interesting stuff.
Sure. So I am a 61-year-old hematologist. I have a wonderful wife and daughter. And I think in summary, I enjoy life and I'm very curious about the world around me. My hobbies, I greatly enjoy reading, which is kind of contrary to what people think, because I usually run around like a lunatic. But just being with a good book is I really enjoy. I'm a very avid runner. And, I enjoy photography and I really enjoy learning new and different things. So that's, I think, me in a nutshell. The odd fact, which is tragic this year because I could not do it, I've actually been to over 40 Bob Dylan concerts in 6 countries.
Oh, wow.
Yes.
I have no follow-up for the Bob Dylan thing. I wish that I did.
I could sing, but...
So I'm actually in the middle of the first Law trilogy, which is this 3 gigantic novel trilogy. So I have no time in my life for any other book. So having said that, if you could just give me a book recommendation, being an avid reader, what can I put on my list of things that I will not get to for the next probably 6 months, realistically?
Okay. I mainly read history books. I would have to say that there is a biography, and of course I'm spacing on the author, of Charles de Gaulle. That is an excellent book. It reads like a novel. He's actually a fascinating character. Really learned a lot of history there. So I'd highly recommend that. A shorter read was a book a couple of years ago called Command and Control, about nuclear accidents, nuclear bomb accidents.
Oh.
Is literally one of those books you could read and not put down. And I think finally, on the theme of the show, while we were down for pandemic, my daughter read In Thin Air, which I read years ago. And that's actually another very exciting, cannot put down book. So I think those are that. My other pandemic project is I'm a big fan of Shakespeare. So I've actually been catching up on, just read Richard III again, and always pertinent to these times.
All right. I'll add them to the list. Fantastic.
Yes. I don't watch TV, so that gives me time to do this.
Avi, is there anything you always wanted to ask Tom?
Oh my goodness.
I've known Tom for a long time. So I actually am curious, what is your favorite failure and what did you learn from it?
Oh, my favorite failure was years ago when I won my first teaching award. A senior faculty member came up to me and says, DeLoughery, every minute you spend teaching is a minute you could have been doing something to be promoted. And I have failed to take that man's advice and failed to do it to this day. And so that is my favorite failure. I've had a bazillion failures, but that's the one that sticks out the most that I've taken to heart. I remember interviewing for residency, and I said, well, I want a job where I see patients, do some research, and teach. No, nobody has a job like that. So, I think part of it is, I think you have to take all advice elders like me give people with a grain of salt.
I like that. So you chose to become a triple threat,
Yes.
a researcher, a clinician, and an educator.
Yes.
That's fantastic.
So you failed to let that person quietly sabotage your career.
That's right. That is the key. Yes. And ironically, it's turned into a great story.
Was there any good advice that you did receive in your career?
Yes. Well, I think the best advice I received, I was at the VA one time as a resident, kind of grousing about things not working. The file room lost my x-rays. And the chief of staff came up to me and says, DeLoughery, if at the end of the day, you haven't laughed about something that happened to you, you're taking it too seriously. And I think that's right. I mean, a lot of things go bad and stuff. I think you got to enjoy life. And as my mentor said, I think for a career, you really got to end up doing something you have fun with and enjoy. And I think I do. I really enjoy what I do. I enjoy all the aspects of it. I enjoy having a job where I can do hematology, which is wonderful, help with medicine, which is wonderful. So I think just not taking it too seriously and enjoying life.
For physicians, this hasn't been an easy time in an already challenging profession. If you're looking for a new position or just starting to imagine what might be out there, our sponsor, Provider Solutions and Development, helps people like you find their next job. For 20 years, they've taken a holistic approach to career coaching that starts with listening to what you are looking for in the clinic and outside of it, and then finding the role that fulfills you. With exclusive access to hundreds of open positions across the country, they're ready to guide you toward the job you really want, from residency all the way to retirement. Get in touch after this show to start a conversation at psdrecruit.org/curbsiders.
All right, so I have case 1 from Cashlack Memorial for us. So Dr. Gotta Climb, a 40-year-old colleague of yours in medicine, shares that they've been invited to go to a mountain climbing / backpacking trip to vacation safely during COVID-19. They're finally going to use some PTO hours after the last 7 months. In addition to avoiding COVID-19 transmission, they say they've never overnighted in the wilderness before and want to be proactive about staying safe. And during your casual conversation, we also mentioned some concern about the altitude. They think they're going to be at about 8,000 feet at least, as they say that they've experienced headaches during a pre-COVID medicine conference at a ski resort in Colorado. So before we really get granular with this case, I wanted to help our listeners with some broader definitions. So can you explain to us what wilderness medicine is?
Well, I think everybody has their own definition of wilderness medicine. It usually involves what they're interested in. But one definition I've heard and I like is practicing medicine in an austere environment. And I think if you look at the people in wilderness medicine, people in the Wilderness Medical Society, that's what it's all about. There's obviously a lot of inches in the woods and the mountains. There's actually a contingent that thinks about space. There's disaster medicine sometimes rolls into it. So I think the very broad category would be really practicing in an austere environment. And then there's a variety of subgroups of that. I think, maybe classical wilderness medicine is altitude sickness, hypothermia, frostbite, heat exhaustion. But there's also travel medicine. You can almost think as a subset of that, and so I think there's a lot of common overlapping things, and so it has a wide group of interests. And I think one of the things that fascinates me about it is just when we go to conferences, the breadth of things discussed and the group of people there. But so I think that's a definition I would like.
And how does one do this? Are there fellowships? Do you just belong to societies? Can you call yourself a wilderness medicine expert if you just read a lot about it? Like, how do you actually get into being a wilderness medicine doctor?
Well, you're in the woods, and the lady of the lake hands you a sword. No, that's how it happened to me. There's a variety of ways to get into it. There is the Wilderness Medical Society, which is the big group in the United States. They have formal programs to get a fellowship. I'm a fellow of their training programs to do. Travel medicine has its own societies and interests. So I think the way people get into it is to go to a wilderness medicine meeting, see what things interest them, get specific training. And so I think it's very addicting, obviously, but I think it brings in a wide variety of groups. But I think most people I know enter it through wilderness medicine meeting, outdoors meetings, and then decide to get more involved in the process.
Now, I know we've done a show on in-flight medicine, and for in-flight medicine, there's like a very specific emergency kit that's kind of the minimum that most planes have. If you were this Dr. Gotta Climb going out into the woods, is there any such kit for wilderness medicine, or is there a place like what would you recommend someone bring if they're going into the woods and they're going to do some pretty serious hiking and maybe be staying overnight somewhere?
I think that's key, and the discussions come up a lot, and we can divide that two things. So emergency kits, what a lot of people actually end up doing is buy an emergency kit off Amazon, then dumping everything out of it and putting their own stuff. And so I think part of it's general to everybody. So, you should have some sort of analgesia, certainly non-steroidals. If it's a major hike, everybody's always had the oxycodone they kept for a rainy day to take with them. There should be oral rehydration, things for anaphylaxis, skin issues. For high altitude, certainly having azetazolamide, even a little dexamethasone there. And obviously a variety of, Band-Aids and, things to make splints out of, ACE wrap. So I think it really has to be trip specific. Certainly something somebody would take for a day hike, overnight hike would be much different than, let's say, a week in the woods or a week backpacking. But I think certainly common things are being common. So pain control, infection, things for sunburn, skin control, rehydration salts can come in handy. For water, there's these straws you can drink out of that purify the water, easily available on Amazon. Things for anaphylaxis and allergies, and then obviously trip specific, like high altitude drugs for this trip. And then one thing which sounds obvious, but I know people run in the woods and discover this, your home medications for diabetic, bring your insulin. And I have a good friend, colleague who's diabetic, who actually wears his insulin on his chest to keep it from freezing. Discovered the hard way that when you go up to extreme altitude, you actually need to vent it or else the bottles will explode.
Oh.
And so, yeah. So there are very specific things. And I think one good thing, again, not to harp on the wilderness medical side too much, and certainly not one of our standard textbook hour back, is actually very nice chapters about hiking and doing things with chronic illness. So if you're a practitioner in the office, like, this guy with diabetes wants to go hiking, what should I do? There's excellent guidance available, and some of the guidelines hit that. So I think both common things and then very specific things can be can be in a kit. I sometimes give a talk on antibiotics in the wilderness, and for most things, actually, augmentin is very good. I'm sorry, clavulanic acid, which I can barely pronounce. I'm from Indiana. I have trouble pronouncing things. Is good.
Amoxiclav. Just
Amoxiclav. Amoxiclav.
Yeah.
I've learned something now. I've
Yeah.
been taught. Amoxiclav. I like that. I'm going to use that in the next talk. Amoxiclav is actually very good if you're pen allergic. It's often, trimethoprim sulfa. Coming up with other choices can be hard, but again, I think a very reasonable thing. And so you really should create your own kit. It's worth the effort. Plenty of Band-Aids are key.
Yeah. So for this, I guess if a patient sees you, you could prescribe them like the EpiPen and some
Yes.
basic antibiotics and stuff, and just and give them instructions on how to take it. Can you elaborate on the rehydration salts a little bit? Like, where do you get those? Is that something that's like a homemade thing? Is it
No, It's easily available. So there's these standard packages, and I think maybe the HWO originally invented them. You mix them with like a pint of water or a standard amount of water, but they're, a salt solution that's very useful for rehydrating. It was actually originally used in diarrheal illnesses for oral rehydration.
Okay.
And you can buy huge packages of these on Amazon. And actually, the travel clinic I goes to, since I have a propensity to get GI illnesses, like give me a case of them. But they're very handy. Boil some water, throw in the salt, boom, you got it done.
As an aside, I wish hospitals carry these, because when you don't have like an IV access for patients, I feel like we should be giving these to people if they can drink. And I've tried to do it before, and it wasn't as easily available as it should have been. So anyway, that's an aside.
Speaking of IVs, like in addition to meds or sort of basic first aid, like do you bring any like more like higher medical grade stuff or stuff in sterile packaging? Like, do you bring an IV? I mean, if you're not like, carrying around a liter of LR, but like, do you bring a stethoscope? I actually saw something online that there was some research about the value of like point of care ultrasound. Which would, the curbsiders are big fans of point of care ultrasound, but do you bring your handheld device, your smartphone?
That's right. I have enough trouble using a stethoscope in my office. So I tend not to be medically sophisticated when I travel. So I tend not to, sometimes larger expeditions may carry, but there's a lot of issues. And if you carry IV fluids, that's a lot of weight. What if it freezes? So people tend not to do that. I think there is a growing interest in point of care ultrasound, again, mainly led by the emergency room contingent. As people get more facile with that, a lot of literature appearing on that. Interestingly, and we'll get to bleeding later, so we'll save that discussion for later, but I tend not to be too medically sophisticated when I travel. And unless people, I think, are going on a huge expedition where they're really going to be away, the space could be better used for Band-Aids.
Okay.
And a copy of Shakespeare.
So you had mentioned, sure, yeah, the heavier versions, ideally, maybe a nice gigantic anthology. You had mentioned one mistake that sometimes people make is just forgetting their home medications. Are there any other common mistakes that people make, or ways that things go south quickly?
There's several things, and I think there's a few. One is the idea everything's going to go great, and it's always a common story. You're out hiking and you get lost. You don't have any food, you don't have any water because you thought you're going to be gone for an hour. So I think people always say expect to stay overnight, or always have extra food, so extra water. And so I think that's one mistake, is not being prepared for bad things. Now, you can get carried away like, oh, what if a meteor hits? But, what happens? People get lost. There may be a sudden shower, and I'll, bring extra clothes. I always have some rain gear shoved in the bottom of my backpack, no matter where I'm at. I tend to do a lot of photography and go out and hike and do photography. And there's always, my camera's wrapped. Of course, if it rains, I'll probably keep the camera wrapped because I spent so much money on it. But I do that. So I think one thing is not being prepared. I think secondly, what we're seeing now is over-reliance on cell phones. They're great. I know right now where I'm at. I have a cheap cell phone plan. I snuck off to Yellowstone this year. It didn't work in Yellowstone, So, if you're just planning that you're only going to navigate by your cell phone, and that it may break, it may die, you may not get that. So, knowing where you're going, having an idea of actually how to navigate or do things, written down on a piece of paper. So I think that's been a second thing, is over-reliance on technology. And it's one of our pandemic projects was my daughter went through. There's kind of a more bit of a fascinating book collection called Mountaineering Accidents in North America. And there's like 60 years worth of data. And her opinion was almost every one of them would start with, then they decided to take a shortcut. And so I think being in a hurry, when you're in a hurry, things are late, it's human nature. I'll take a chance, that maybe an avalanche risk, but I think today it looks okay. And so people being in a hurry, but again, it's easy to see, we've all taken shortcuts. We've all been in a hurry. We've all run yellow lights, but it does every now and then catch up with you. So I think those are the kind of things people need to think about. It's not going to be perfect. Technology may not be your friend. And, if you're very goal directed, I'm going to get to the top of that mountain. I'm going to finish this hike no matter what, read in Thin Air about that. Yeah. Or, boy, I got, I got to get back home, or, my friends will be upset with me. I'm going to take this shortcut. I think that's usually the universal way of how people get into trouble.
Okay. So I want to briefly summarize, and then I think we should go into talking about some of the specific
Sure.
Afflictions or issues that people might get into. So antibiotic wise, you said amoxiclav, maybe trimsulfa. I was thinking also maybe doxy for,
Doxy's very good for unusual things. So,
yeah. Some sort of a kit for anaphylaxis. So probably like antihistamines, EpiPen, and then hydration salts, plenty of water. Make sure you bring your home meds if you have chronic medical conditions. And sun protection and maps. Just don't plan that your technology is going to be with you, and plan maybe things won't go so well. So we have
maybe extra clothing and a little bit extra food.
Got it. So we have Dr. Gotta Climb is now at altitude, and we mentioned that in the past this person has had a headache going to altitude, and now this hike is going to be over 8,000 feet. So what exactly is like altitude or altitude sickness, and can you talk about like the spectrum of that?
Yeah, so it's actually a very common illness. So people, they're susceptible people, but people, especially if we go to altitude fast, will get a constellation of symptoms. So almost always it's a headache. Some people get nausea, vomiting, can get fatigue, lassitude, and so that's been called acute mountain sickness. It's pretty common. We tend to think of it as some esoteric thing, but there was a study years ago, I believe in the Annals, where at a medical meeting at a ski resort, they actually just passed out, a survey. Do you have these symptoms? And 40% of people had the symptoms of altitude sickness. A lot of it is, I got a headache, it's jet lag. But, when you go and, I feel like even, going to Yellowstone at 8,000 feet, you feel draggy for a day. And there's a lot of reasons, but it's probably part of it. And then it can evolve, and sort of the spectrum goes from getting worse headache, and sort of the end stage, which rarely, fortunately, happens, is like high altitude cerebral edema, where your brain swells, and that's sort of it. People vary with it. Some people are debilitated by the nausea and vomiting, debilitated by the headache. So I think that's the first big illness. The second big illness is high altitude pulmonary edema, a non-cardiac pulmonary edema. Strong individual susceptibility, again, has actually been reported at ski resorts and ski altitudes. Maybe it's rare, 1 in 1,000, but how many people ski? And certainly much more common as you go to higher altitude. So I think those are the two general ones we tend to think about.
Okay, so there's the more of like the AMS, the acute mountain sickness, right, and the cerebral edema, high altitude cerebral edema, those are kind of a spectrum.
Right.
Then the separate illness is this high altitude pulmonary edema.
Correct.
So how would you tell this person to ascend so that they are at less risk of getting this? And maybe how they climb the mountain, how does that work? Or do they need to take medications to prevent this? How do you coach people?
Yeah, so there's a very, very nice summary and actually the section on this in Up to Date is excellent. Peter Hackett and several other people were the authors, where they really go by risk stratification. So, a very slow climb, taking your time, very low risk. Literally like going up Kilimanjaro in a week, very high risk. So you can do some risk stratification. And one thing Dr. Hackett recommends kind of nice is, just simply draw a graph of the trip. It's like going like that, it's high altitude. Part of it is slowness. Dr. Hackett did a nice study years ago. People that went to the base camp of Everest in a day or two had an instance of altitude sickness of up to 50%. Those who hiked took a week, it was down to about 10%. So, when people go above 3,000 meters, try not to go above 500 meters a day. Having a rest day every now and then it seems to be key. So slow and steady. And most planned hikes in high areas, expedition hikes, have that planned in. The other thing, which you read in the mountaineering literature, people always like go to base camp, they build camp 1, but go back to sleep in base camp. They go to camp 2, they build camp 3, go back to sleep, and trying to be very not trying to sleep at a new altitude every night. So those are some of the ways you can do it. Issues with that is some things just are faster than usual. And again, we don't know why. There's an individual susceptibility to mountain sickness, and some people are just going to get it. The workhorse has been acetazolamide. It speeds acclimatization. You breathe a little faster. And it's really been the workhorse of altitude medicine. Studies have shown a preventive dose of 125 BID is very good to prevent this. You take it and then you continue for 2 to 3 days at maximal altitude. It's a therapy for acute mountain sickness. Rare people, especially if they've had severe mountain sickness, may add a little bit of dexamethasone. Again, the issue is it doesn't acclimatize people. It just makes them feel better. But really, acetazolamide for most people be the workhorse. At these low doses, the side effects tend to be low. There's even controversy you can go even lower, 62.5 milligrams BID. One study was positive, one was negative, but most do well to 125. So I think for people who've had bad AMS in the past or on aggressive climb, using acetazolamide there. Side effects, it makes beer, cola taste flat. It may cause a slight decrement in exercise performance, but, compared to barfing your brains out, it's probably a good trade-off for some people.
I wonder if the dexamethasone in this case is mostly having like antiemetic properties.
Right.
And it looks like it's a reasonably high dose. It's 4 to 8 milligrams every 6 hours or so, depending if you're. And is that mostly just for treatment, or do you use that for prevention in some cases as well?
Rarely, mostly for treatment, but there are patients who, let's say, may go to Machu Picchu, have a very aggressive climb. They've really had bad altitude sickness. At least give them some as preventative for a day or two, or at least have a board for treatment. Again, as a hematologist, I actually tend not to like steroids and having people on steroids.
Yeah.
Sure.
Yeah.
It's going to mess up the
Because
biopsy you need
natural.
when they descend.
I know. They have ITP at altitude. It's handy too. So.
Okay. And then, so that was for acute mountain sickness and the high altitude cerebral edema. What about for HAPE, or high altitude pulmonary edema?
So there again, judicious climbing, altitude is key. Again, what's surprising is if people have had HAPE in the past, they're more likely to get in the future. And so a preventative is using nifedipine as a pulmonary vasodilator, because the pathophysiology appears to be an accentuation of the hypoxic vasoconstriction we see in the pulmonary arteries. There was actually interest in using 5-phosphodiesterase inhibitors. That faded from the scene, both due to cost. They seem to get confiscated at the border a lot, and it didn't surprisingly do anything for altitude sickness. So I think people are back to using mainly nifedipine.
And oxygen, I was curious to see that oxygen didn't really seem to have as big of a role in any of this as I thought it would.
And I think part of the issue is you're not really, most people aren't carrying oxygen tanks or doing oxygen. So the way we recommend for oxygen are kind of cute. One is just descend. If you descend, the pressure of the air is higher, you get oxygenated. Secondly, there's these big bags called Gamal bags. So like giant balloons, you stick the person in it, you zip it up, and actually somebody pumps it up, and you literally increase the air pressure inside. They fall relatively like by 4,000 feet. And again, that increases their oxygenation. I also think it's a good test for mental status, because as an experiment, somebody zipped me in one once.
Oh
and it was so claustrophobic. If I had a knife, I would have ripped it and had to buy a new Gamal bag. But those are the tricks for oxygenation, is trying to descend, or like many, big expeditions will carry gamal bags because conditions may not allow you to descend.
So I think we've covered. I think we've covered the high altitude sickness. Are there any other key points about this? So it sounds like take your time, maybe some acetazolamide if people have had trouble before, carry some dexamethasone in case people get sick as well, and then and nifedipine if they have pulmonary edema issues.
Yeah, and I think also again recognition and being slow about it. When you read about people really getting into trouble, they're like, I paid for this expedition. I'm going to go up. I don't care if my head feels like it's blowing up, and then their head blows up.
Yeah.
And so again, I'm going to sound like a broken record, but taking your time is very important.
You had mentioned there's individual susceptibility. Are there any medical conditions which may predispose people to altitude sickness?
Not as much altitude sickness. There's interestingly people who like have already have pulmonary artery hypertension, or obviously have a single pulmonary artery has been that. But it's actually, there's been a lot of work and not much consensus on genetic or other risk factors, or is there a predictive score than simply a history? Younger people tend to get it more than older people. There's this whole theory that brain volume matters, but surprisingly, even with Clair's interpersonal susceptibility, there's still some debate about the genetics.
Interesting. And since
My
we're talking,
cerebral atrophy is paying off, it sounds like. That's
Yes.
Great.
That's, like I said, it's just, hematology feels just riddled with AMS due to the big brain volumes, but it's just us.
and then while we're on the subject of ski resorts, what should we be counseling our colleague in terms of the risk of exposure, both particularly hypothermia in this case?
So hypothermia can be insidious, and what's interesting is that we've seen a variety of life experiences. We see unfortunately patients in the wintertime, especially in Oregon for some reason, become hypothermic. But a lot of these are people not dressing for the elements, or getting too cold. There's the old saying, cotton kills. I'm sure you'll get an angry letter now from the cotton industry, but, it gets wet, you get cold, you get it. And one thing that can be insidious a little bit about hypothermia is that some people get this very paradoxical reaction as their brain gets cold, that they strip off their clothes and run around and kind of lose cognitive function. So some people, it's easy to slip into hypothermia. There's the classic, people, getting lost, falling in very cold water. So it can be a common thing. That's where, trying to wear layers of clothes, at least having your buddy recognize you're being cold. One interesting defense mechanism we have is actually shivering. Shivering is actually increases your metabolism 5 times. And there's been studies where they've cooled down people, give them Demerol to stop their shivering response, and their temperature just keeps falling. So that's where food comes in. If somebody's hypothermic and you have a cold Coke, give them cold Coke, because that's going to give them glucose so they can shiver. Drinking the shot of whiskey probably is not going to help. The rescuer drinks the shot of whiskey. The cold Coke goes to the hypothermic patient. But that's one little trick. So hypothermia can be insidious in some people, and certainly people are buried in the snow. They get trapped overnight. That's where we see hypothermia. One issue we also see with hypothermia is sometimes you find somebody like, boy, we found Bob. He's been lost. Wow, he's really cold. You get Bob up and try to move him around to warm him up. Well, Bob's vessels were clamped down. You get him exercising a bit. His core blood goes out, gets cooled down, and then Bob has cardiac arrest because he has something we call afterdrop. So actually, when somebody's hypothermic, try not to bang them around too much. You lower the VFib threshold is also key. And there's actually been reports of people rescued at sea. When they're, flipped up vertically, they arrest for a variety of reasons. So actually being calm and collected during the rescue or resuscitation is a key.
If people go to BICO rescue.com, there's this cold card thing. And I thought that was pretty great. It's a really great infographic that talks about hypothermia, and it says you're supposed to assess consciousness. Mm-hmm. Is the person moving? Are they shivering? Are they alert? So the best, if they're doing all 4 of those things, it could just be cold stress. And like you said, those are people that you could exercise. Mm-hmm. And then as the person got sicker on that cold card, it's like, keep them horizontal. Don't move them. And I was wondering why that was. And you just explained it so nicely that you don't want to.
Card is wonderful. So that's a very nice, I'm jealous. It's like a very nice, one card explanation of a whole vast field of medicine. So I should make
Yeah.
one for hematology. Just say iron, but
Oh,
And a big no symbol on top of an IVC filter.
yeah, that's right. That'd be my home card. But yeah, the cold card's wonderful, but I think those are the general keys, and it
Yeah.
can slip up on people. So
this is not a point even worth making, but one of the things I enjoyed while reading up on this is the Swiss hypothermia classification system. And I'm just fascinated that there is a stage 5, which is death,
Yes.
which seems unnecessary. I think once you got to stage 5, you probably don't need to classify it. I think you probably crack the case without hypothermia.
Well, it's interesting, and their definition is, I forget, 19.7 degrees Celsius, which happens to be the temperature of the survivor. What if somebody's 18? They'll never get to be a survivor. The other thing that fascinates me about, I think it is a true rule. It's an old saw, but it's true. You're not dead till you're warm and dead. And, there's just amazing survival stories of, kids being underwater for 60 minutes, being resuscitated. Because one protective thing about hypothermia is your brain shuts down and you dramatically reduce metabolism. So, there's stories of people not being resuscitated, getting CPR. I think there's a record of a guy getting ECMO and CPR for 8 hours, having full survival. So I think that is true. What is interesting is multiple articles say, when can you say somebody is cold and dead? They always mention truncal transection, which I usually never thought was a big issue before, but
Wait. Truncal, I don't, what does that mean?
I think it means being sawed in half.
Oh, yeah, I was like, okay, that's what I thought.
But what's interesting is it's in multiple papers on the subject. I'm like, it's not a problem I've been familiar with. Maybe it's big in Europe.
It's some weird meme that made it into.
Yeah.
This episode is probably airing after Halloween, but we're recording a couple of weeks before Halloween, and suddenly what am I going to do for Halloween for my kids who are on quarantine still and can't go trick or treating, and you can't see me right now, but my jaw is on my desk because I'm just like, I'm trying to reconcile this and the calendar right now.
That's right. Truncal track. Well, I think of those magicians sawing people in half. So, but I think that is a thing. So if you find somebody who's cold, their pupils are fixed, they don't have a pulse, they're breathing one time, they're not breathing, they could be resuscitated. So I think that's the one lesson is truly. People are very cold. It's very reasonable to try to get them as fast as possible to an ECMO or dialysis center to warm them up. And there are survivals. European experience, again, has a high survival neurologic intact data for people who were basically very, very cold. So I think that's the one key is not to give up on people too early.
Can you talk a little bit about if someone has wet clothes, like how to handle clothing when someone has hypothermia? And I imagine some of that depends on what you have around, like if you have dry blankets or something around. But can you talk about how to handle that if you're out in a austere environment?
Yeah. So one thing to do is with clothing is, obviously if they're dry clothing, it's worth changing, but that often isn't there. One trick is try to separate them from the ground. You lose a lot of heat through conduction in the ground. The ground's very cold. So again, that's where this burrito idea comes in. If somebody has wet clothing, you're kind of stuck with it. So people recommend wrapping them in a vapor wrap or a tarp, and then wrapping them in sleeping bags or other things, just to try to prevent further heat loss. If the clothing is the temperature of the body, and you prevent evaporation, they're not going to get any colder, but is try to prevent evaporative and other loss. So ideally, but nobody, has, here I have, my change of clothes with me. We'll dress them in a suit, but doing something for a vapor wrap, wrapping them up in the burrito. So the idea of the burrito is try to prevent further heat loss. And so even in wet clothes, you gotta sometimes play what you're dealt, and trying to prevent further heat loss is key.
And they mentioned applying heat to the core.
Yeah.
And they show the chest and the axilla
Yeah.
on that diagram. Are there certain warmers that people carry with them that they can do that with, or is that just that's where you put dry clothing or?
Yeah, so some people will carry, or somebody has a quick rescue kit of literally the warm packs you can put in there. The warm packs you can put on the necks, but the physics of that is difficult because if you remember, it takes a lot of heat to heat up water, and so people have experimented, even given IVs and other things, and it may help a tiny bit, but I think really the key is try to get them somewhere where they can be definitively warmed up.
Okay.
So we talked about hypothermia and that sort of exposure, but tell us more about frostbite and like, can you get frostbite if your core temperature is not dramatically low, or like, what's the setup? What's the illness script for frostbite?
Yeah. So frostbite is actually very, very common. I've had it frostbite. I've known a lot of people have frostbite, and it can be a pretty good core temperature because, it's your extremities that get it. So, there's a variety of setups, when you're climbing or hiking the snow, your feet are going to get very cold. The ends of the feet, especially the circulation goes down. And that's a very common situation for frostbite. People can get frostbite on their extremities, their ears, their ears, their nose, from decreased circulation. So surprisingly, frostbite is to some degree, is very common. And, there's always these horror stories, but you see people on expeditions who get lost. They have to stay overnight, outside, and they lose, they get their fingers or toes frostbitten. Great story about the first climb of Annapurna, but called Annapurna, where actually people lost their gloves and they still kept climbing because they wanted to be the first people, they want to climb Annapurna, and they got very severe frostbite. So frostbite, especially for climbers and outdoors, is pretty common, and a lot of people have had a little frostbite, little nip. And again, the risk factors are, too tight boots, not enough padding, and it's insidious. Again, you're not feeling your hands, and you sort of don't think about it too much. And it's like, wow, my hand is cold. So it's actually some degree of frostbite's pretty common. Fortunately, the horrific cases are pretty rare, but it's some degree is common.
So frost nip, from my understanding, frost nip is more of like a superficial. You might see actual frost on the skin.
Yeah.
Is what I was reading. Yeah. And then frostbite is where the actual, like, the tissue is of the extremities, or the superficial tissues are actually frozen.
Right.
And you can start to get like blisters and discoloration. You can get like blood-filled blisters or bruising, right? Can you talk a little bit about like what it looks like?
Yeah.
And
well,
how we
what's
might
interesting
recognize?
is if you see people with very severe frostbite, it actually, quickly looks okay. I mean, it's sort of like, well, it's kind of pale, and then, you hit it and it's rock hard because it's frozen. And then there's an evolution. So you see clear blisters, blood-filled blisters, a lot of controversy in the field about which ones you pop, which ones you don't pop. And then you can start to get frank gangrene of the toes of the area. What's a difficult thing is that often the extremity will look a lot worse than what the final disability will be. So, I mean, the fingers may be all black to the hand, and then at the end of the day, when things have fallen off, maybe you just lost your fingertips. And so it's an interesting change in the field. It used to be said, well, you get frostbite in January, you do surgery in July, you give time for things to heal. It doesn't work. We're a go-go society. If you're, a famous podcast host, you don't want to be not using your hand for 6 months. So some people are now willing to take earlier surgery, maybe more aggressive amputations to get back to work early. But there's a progression from, mild cases with blisters to, the very severe cases with really frank eschars and, frank dead tissue.
Let's say our patient, like, for some reason lost one shoe or a boot when they're out there.
Yeah.
And they have a foot that is a little bit white and it's numb and it feels hard. Like, we think it's frozen. Can you talk about whether or not they should try to walk on that to descend and what you would do to that acutely to try to treat this?
So one thing is that, again, if it's the way to get definitive help, it's probably worth doing. If you think it's faster, they can't be evacuated quickly, it's faster to descend, you descend on the frozen foot. The worst thing you can do is like build a fire, try to thaw it out, and then it refreezes. You might as well just chop it off.
Right.
That's the worst thing you can do. So again, sounds horrible, but that's austere medicine is make sure it doesn't thaw until you definitively thaw it. So, if that's the only way the person can evacuate themselves, or it's by far the quickest, getting them to definitive help is quick. So painful as it sounds, walking on it's probably the best.
And what about, let's say we get the person, we get gotta climb down, we get them down, and now we need to rewarm it. what sort of thing, like what's the proper way to rewarm somebody? I have not done this before. I mean, you go out and shovel snow, your hands get cold.
Yeah.
You run it under some like warm water. They feel better after 5-10 minutes, whatever. But what do you do somebody with frostbite?
That's literally it. You get some, ideally you get some warm water about, 40 degrees, not enough to burn anybody. And you literally stick it in and thaw out the affected limb. It may take 20, 30, 40 minutes, but you do it. Some people just run it under warm water. If you have a whirlpool, that can be very handy. That will thaw it out. The one thing is that can be incredibly painful. If you've ever gotten cold and it rewarms, and so people may actually need narcotics for analgesia. Well, having some pain is probably good because that means there's viable tissue. So literally using water to warm it up, there's horror stories of people like sticking their hand near a fire and then they just end up burning off their hand. Don't do that. Pro tip, don't do that. But rewarming's key. People often advocate giving aspirin or Motrin slightly for pain control, reduce bad cytokines and prostaglandins. And, we're into this idea that a lot of it may be actually vascular thrombosis. Yes, the hematology works in thrombosis. And so may help with antiplatelet effect. But trying to judicious rewarming is key.
Yeah, and in the hospital, I've seen them use like warm IV fluids at times. Is that something that should be commonly done? I guess if we get these people to the hospital and the hospital giving the warm fluids could supplement that as well.
Could also supplement that. And then one other thing that's very interesting is that there are prediction rules of how bad the defect will be. And there's been a strong interest in past decade in actually using thrombolytic therapy, catheter-directed thrombolytic therapy. Again, there's no randomized trials. It's the old, here's what happened before, now we do it, people do better. But that's become pretty aggressive. And the idea is, especially in your hands, if you can save more tissue, the better. So if you got a young guy with severe frostbite on both hands, saving a little bit of tissue could really make the difference in their life. And some have even proposed, if you're really in an austere environment, can't get, to a place to give TPA in 24 hours, you just empirically give TPA. So I don't recommend that for like Philadelphia, but backwoods Philadelphia. But some of the people in very austere environments have done that. Again, the argument would be, young guy, we want to save as much tissue. But that's been interesting. There's our friends, the interventional radiologists, have been very aggressive in thrombolysing people within 24 hours.
Wow. Okay.
See, I was going to ask you earlier if you brought tranexamic acid in the field, and now you're talking about TPA. So I feel like we're just like overshot.
That's right. I make it clear I do not carry TPA in my safety kit. So
Okay.
I do carry aspirin.
All right, so let's transition on. So we've talked a lot about cold people. Let's talk about heat exposure. So can we talk a little bit about the opposite situation where someone gets overheated and sort of what the spectrum of injury looks like and how we should manage that?
Yeah. So the spectrum of injury, there's heat syncope where you're standing out, it's hot, you're dehydrated, you keel over. Heat exhaustion is pretty common, and that's where people get hot. They may get a little confused. They're dizzy. They're pretty confused. The end stage is heat stroke, which is really people. Basically, I think of it as people being unable to thermoregulate anymore, and their temperature shoots to 105, 108, and they literally cook their tissues and get tissue necrosis, brain damage, liver damage, kidney damage. It sets up a very intense inflammatory response. And so this is, again, where prevention is key. That's why there's a lot of rules about working out in the heat, humidity. One thing that people get prone to it is sort of like, hey, I just flew from Portland, Oregon to America Samoa. I'm going to go for a 10-mile run and it's 90 degrees and humid. Fortunately or unfortunately, most people just get heat exhausted and keel over there and that stops them. But if people actually do it again real soon, they're more prone to heat stroke. So they're both recognition because people can get very confused and like, boy, they're running, they're staggering, they're hiking, but they're not making sense can be key. And again, rapidly cooling down people. And one thing the military has found is very effective is just throwing water on people and fanning them, getting evaporation and trying to get them down to about 100 degrees Fahrenheit can be done. But heat stroke can be very nasty and a very fatal disease. But there again, recognition and especially prevention is key.
And I in the pre-reading, it seems like all the papers that talk about this discuss medications that can possibly predispose you. Do you mind talking us through some of the more common ones that?
Yeah, so certainly tricyclics, any cholinergics can increase the risk because it blunts the sweating response. Another one, is obviously amphetamines, drugs like amphetamines, and I think was it ephedra, a drug that was out a few years ago, actually implicated in some heat stroke deaths. That can lead to it. Some of the antipsychotics can blunt the heating response. Older patients, because they don't have much of a heating response, can be prone. And then really acclimatization is the key. If you want to go somewhere and exercise, very gradually getting into it over 2 weeks can do well. I mean, I grew up in Indiana and could go running in 90 degrees humid weather in the afternoon because I was acclimatized. If I did that now, I'd be dead in 3 blocks.
I don't mean to laugh at your death. I just,
you did. I'm very offended by it. But
so heat stroke. I always had trouble remembering heat stroke, heat exhaustion, heat stroke. Yeah. I think the formal definition is like greater than 104 Fahrenheit, and they have CNS symptoms. So stroke, right. CNS. That's how I remember it from now. And then I like the guidelines from Wilderness Medicine. They said a drink to thirst approach is good because there are these stories of marathon runners, right? Drinking too much and having hyponatremia. But if you drink to thirst, it seems like that's a pretty safe way to avoid that.
And that's one thing. We grew up in a society that seemed to really overemphasize drinking. Keep drinking water, drink more, you're going to get dehydrated and die. And almost all the bad hydration issues and deaths and marathons and stuff has actually been hyponatremia from people drinking too much water. I run half marathons and I run them very slowly. Me and the snails are racing. If I were to drink at every stop, my sodium would be 92 by the time I was done. And so really drinking to thirst. There's been actually fascinating studies where they compared prescribed drinking to thirst, and actually for things like half marathon, no drinking. And people who don't drink actually seem to run a little bit faster. Maybe they're thirsty and they want to get to the finish line. But so I think the idea that especially in marathons, half marathons, you're going to shrivel up and die from dehydration or even impair your performance is pretty wrong, and really being very judicious in drinking fluids.
Awesome.
Seems like judicious is just the theme in general.
It is. You got to be judicious. I know it's no fun to be judicious, but
it's safe though.
That's right.
We're safer.
That's right.
All right. I think we have another part to this case.
We do.
Avi, you want to?
All right. So Dr. Gotta Climb has had a fantastic time on the mountain and fortunately did not develop significant high altitude sickness. In fact, because they were so prepared and brought extra clothes and food, they decided to spend an extra night in the wilderness before returning home. In the middle of the night, though, they wake up to something moving around the tent, can't get a good look at it, and maybe feel like a scratch on their shoulder as they're unzipping the tent and shooing it away. They never get a good look at that juncture, but when they wake up in the morning, they notice 2 red marks on their shoulder and are worried that they've been bitten. So tell immediately, what is your concern? What's going through your head, and what's the burden of suspicion in this scenario? And then we're going to hopefully talk a little bit more about animal bites more broadly.
Yeah. So I think one thing with this scenario would be, is this a bat bite? Bats bites people. And they can be very subtle. The bats have these very sharp little bat teeth that can really inflict a small wound on people, but be fairly asymptomatic. And people who are asleep, people who are impaired can get bit by bats and not even notice it. So you're like saying, well, great, I'll turn into a vampire. But the problem with bats are that a high percentage of bats actually carry rabies. Interestingly, like many infections, rabies does not harm bats. So they're effective spreaders of rabies. And, I was reading the other day, for obvious reasons, that like up to 10% of the bats tested around in Oregon actually are rabid. And so the concerns would be, was this a rabid bat? And I think from the fact that there probably was a bat bite, the bat's long gone, you can't kill it and do a rabies test on it, that this person probably needs rabies prophylaxis, because rabies is a terrible way to die. If you don't remember anything else, don't die of rabies.
So Tom, for those who may not be in the loop or follow you on Twitter, can you explain why you said for obvious reasons?
Yes. So because I was running about 6 weeks ago, actually felt something on my head. It was a bat. Actually had a bat bite on my bald head, and ended up getting rabies immune globulin infiltrated in the wound, did some shots in my behind, and a series of rabies vaccinations, which is actually bright purple. It seems like you should get superpowers with it. So this sort of focused my attention on rabies. Even though ironically, I actually have a talk on rabies, but that was based on personal experience. But it's very, bat bites are very common. I was the fourth person seen in the urgent Clair clinic this summer with bat bite. And so the difficulty with bat bites is that they can be subtle. They high chance of being rabid. And even if you get scratched by their little bat feet, bat lick their claws and scratch you and give you rabies. So they're kind of fascinating creatures, but unfortunately can be very rabid. So and prophylaxis is key. So if you've never been vaccinated before, immune globulin infiltrated in the wound, and then the rest of it infiltrated in your butt. A series of vaccinations, now thankfully down to 4 in each shoulder. I don't know. When I was a kid, I was always told if you touch something dead, you had to get 28 shots in your stomach. And I didn't know if that was real or just something my mom 100%. Said to keep me from playing with dead people.
I never heard that.
Really?
Oh,
really?
No, I was thrown with that all the time. Squirrels specifically. Like if you get them, you have to get just a bazillion rabies shots in your belly and you may still die. So
I grew up with the you got to be careful. You're going to get a huge long needle in your stomach. I have no idea where this came from.
Yeah. I would have to say, I would still have to say the shots, especially the last few ones, hurt like hell. So I would still not recommend getting it. But one common trick, and actually for all animal bites, again, it's common sense, is washing with soap and water. There's experimental studies that will actually reduce the chance of getting rabies by 50%. I didn't want to take that chance, so I did more things, but I washed with soap and water. Actually, I have to be honest, I completed my run first because I was so shooken up and still spewing so many obscenities that I kind of had to run it off to, which may have had a cauterizing effect on the wound.
You know what I thought was funny?
Again, coagulation.
So if someone gets bit by a dog and it's a dog that you know and you can observe it and it's still alive in like 10 days, you can say that dog probably doesn't have rabies because it should have died by now. But I just thought it was funny that when I was reading about this, it's like, if you can observe the bat for 10 days, I'm like, who's observing a bat? Like, who's? Yeah.
This really is the Halloween episode that wasn't.
Like I thought, I was like going, oh yes, I should have grabbed the bat, calmly put it somewhere, and I was just too busy screaming.
Yeah, I'm thinking of Ace Ventura too right now. We should. So bats, and what other animals do you think about that where people would need rabies? Is it? Does the list matter? Just any animals you get bit by, just go talk to your doctor.
Some are more high risk than others. So raccoons are very high risk, and foxes in certain areas, mongooses, jackals. I don't think there's any jackals. The Oregon jackal. The Philadelphia jackal, a very very common issue. I'm sure you dodge them on your way to work. Those are animals that are most common. Surprisingly, in the United States, actually more cats than dogs have rabies. So I apologize to all the cat people out there. And that's because in the 1940s, there was a big campaign to vaccinate dogs. So actually the reservoir in the United States, dogs are very low. Worldwide, any feral dog that bites you, you're going to get rabies. But in the U.S., and there's I know the Oregon Health Department has it. I assume other people do, but there's actually very nice guidelines by the health department sort of stratifying what to do with certain animals. And, bats are basically, if it bites you and you can't examine its brain, you got to get it. Dogs, observation. But in general, it should be a consideration, especially in any animal that's acting weird, raccoons, foxes, and carnivores especially, it can be a concern. But again, there's been rare reports of rabid horses, cows, which just sounds frightening. So there's all sorts of horror stories out there, but it's usually the classic suspects.
Let's say instead of a bat, let's say that you were trail running, and you stepped on a rattlesnake. You get bit by a rattlesnake.
Yeah.
I just want to throw some stats out there for the audience because this is like one of my favorite things I've read in a long time. So there's about 9,000 snake bites that go to EDs. This is from the Wilderness Medicine Guidelines. 9,000 bites that go to EDs for treatment, and about a third of those, so like 3,000 of those, are from venomous snakes like pit vipers, which are cottonmouths, rattlesnakes, or copperheads.
Yeah.
And only 5 to 7 people die from snake bites each year. Which is, I was very reassured from that as someone who is pretty scared of poisonous snakes, even though I don't know that I've ever encountered one in the wild, thankfully.
Of Philadelphia.
My second favorite stat. Well, I lived in Texas. We were hiking in Texas, yeah, and fortunately, yeah. So, my second favorite stat about this is that most people that are bitten by snakes are young men. Between the ages of 18 or 34, and it's usually on an upper extremity, because they were messing with the snake. And my answer to that is, why are they messing with the snakes? Like, what is it? And most of the time they're intoxicated, so that's probably the answer.
It's amazing. We actually had a guy 15 years ago actually made the national news kiss his snake, kiss his rattlesnake. Yeah, that. Tongue swelling, trach. And there's, and for my talk now, there's a picture of a guy who took a selfie with a snake, and now he has a lot of selfies of a swollen arm. So, yeah, snakes, young men, and alcohol don't mix.
Yeah, I mean,
the triangle. I don't know if it's like, maybe it could be my triangle. Vercal has mine. Mine could be, mine could be young men, alcohol, and snakes. The DeLoughery triad of doom.
So, tell me, I read that even if a snake is dead, that you have to be careful. And even if the snake is decapitated and you're just messing around with the decapitated head.
Transaction, it comes back.
So tell us about that. Have you actually seen or heard someone getting bit by a dead snake?
There are stories of that. If you just go and like kill the snake, like, damn you snake, you're dead. The snake still has its reflexes for a while. So there are reports of people thinking they killed the snake or actually killing the snake. And then, they prop open their jaw to look at it. It bites them because of a reflex, which really seems to add to terribleness. Or literally, like, I'll chop off the snake's head and
What have you learned?
Yes. Obviously, if the snake's been dead for 3 weeks, the ghost of the snake of, snaky past isn't going to attack you. But dead or near dead snakes still can be pretty angry. So there's a wonderful meme I show in my talk is, people always argue about the coral snake pattern. What is a red on yellow, kill a fellow? And there's a lot of things with that. So it's the old Batman and Robin thing. And, Robin saying black on yellow and Batman slaps him. Just don't touch the damn thing. So I think that's the best things with snakes. Unless it's a little garter snake, just don't touch the damn thing.
I like the practical advice too. Like, if you are bit or if someone's bit, like, get away from the snake and then take a picture of it, because that can help determine if you need anti-venom, because like, I'm sure once a snake's bit you, it suddenly becomes like the biggest rattlesnake you've ever seen. And but the picture, they say that could prevent some like unneeded anti-venom or hysteria if you find out, oh, that's not even a poisonous snake. That just bit you.
Try to get a picture is key, because again, killing the snake, you'll end up getting bit more. And then you read these people. Well, look at the anal plates of the snake. Let me look at my field guidance anal plate. Just take a picture of the thing. And what's interesting is, even with rattlesnakes, 25% are actually dry bites. They bite and they don't inject venom, but still got to observe the patient. But yeah, taking a picture. Don't look at the anal plate.
I think Matt and I were mildly devastated to find out that the mainstay of the movies that we grew up with in the 80s and probably early 90s, in terms of sucking out the poison, is not a thing you're supposed to do. I was disappointed to hear that. But what are we supposed to do other than getting a picture of the snake and possibly checking out the anal plates?
That's right. So the key is, I'm going to sound like a broken record, is right now it's just the only good therapy is anti-venom and getting them to healthcare as fast as possible. And again, if you're bit on the leg and you can run to your car and go in, that's the thing to do. The problem with this idea of sucking out the venom is a few things. It's the basis of many bad jokes. It's you damage the tissue trying to make the cut in it. The venom infiltrates very rapidly, and so you can't really suck it out. And, you're wasting time doing it. So, and some people have experimented with tourniquets, probably not ideal. There's maybe weak data that if you're bitten by an Australian snake, that wrapping a tight tourniquet to prevent blood flow, but you're just wasting time. The definitive therapy is anti-venom and getting the patient somewhere where they can get anti-venom. If you really are into this, Wikipedia actually keeps a list of everybody in the United States that's died of snake bites. So maybe when you're watching TV, you can check out the list of people who have died of snake bites in the United States. One thing's amazing, though, maybe 5 people die here, but actually in countries like India and Asia, the death rates from snakes are phenomenal because they have more cobras and neurotoxic snakes, which are a lot more deadly. These people are going to rice fields, get bit by a snake, and that's it. So worldwide, it's still a big problem. And again, here it's usually people running or stepping on one or drunken young men.
Yeah. I read that the snake bites, the way people get sick from these, like it can cause DIC. People get like they can get like CNS involvement, hematologic involvement. Anything else interesting to talk about, like as the after effects from a snake bite? Like what do these people die from if they die?
So if they die, it's usually DIC. Sometimes they get, especially like the most important thing, like an IV shot of venom. Actually, people do get dysrhythmias, cardiac effects, but most time with the vipers, it's local destruction. Metalloproteases destroy the tissues. You get DIC. You get a lot of local tissue necrosis. Thrombocytopenia is interesting. It's actually the snake venom aggregating the platelets, but it's reversible. So the platelet count will go down. You give them snake venom, it goes back up. You don't give them enough, it goes back down. That's what they die of. Coral snakes, cobras have neurotoxins, and it's a paralytic death. And it's interesting. If you look on Up to Date, the coral snake anti-venom has expired, but Up to Date will give you the exact lot number you should get. I don't know if you can get from Costco, but so there's still a little magic. And I always recommend if people get bit by a snake, call a poison center because they know the tricks. But with rattlesnakes, vipers, it's usually local tissue destruction. One scary fact is that copperheads and water moccasins can reproduce asexually. So if you need something to worry about, that's
nightmares tonight.
That's right.
Oh, so this is the last case. Avi, do you want to introduce it?
I'm happy to introduce it unless we want to make Paul read the terrible pun of a name.
Paul?
Yeah, no, sure, I'm game. So Dr. Klime's camping partner, D's ending, read without comment, gets excited as they reach a trail marker that says they are 2 miles from the parking lot in the final stretches of their return hike. I actually like this case a lot because it takes a twist. Unfortunately, they lose their footing and careen down the steep embankment through the brush. My favorite sentence of the case, you don't think they lose consciousness as you can hear them shouting the entire time. Probably followed by the exclamation, "Oh my God, that's a lot of blood." So this is I think our transition into the first aid and hemostasis, your bread and butter. So,
Yes.
So tell us, in addition to sort of the basic first aid stuff that you might bring along with you that we talked about earlier in the episode, what kind of advanced skills should we have as we head into the wilderness or into potentially dangerous situations, and how might you handle this specific case depending on what the injury is, I guess?
Sure. So, kind of the old tried and trues, again, are happening. So a lot of injuries can just be taken care of by just simple direct pressure, getting the dressing, putting firm pressure on the wound for 15 to 20 minutes. My surgeon friends really love it when they call me for a consult, and I just recommend direct pressure. But that can be a very useful technique. There have been interest for more devastating wounds, and especially, unfortunately, like civilian terrorist in more aggressive form. So tourniquets have made a comeback. Tourniquets were poo-pooed forever, like, oh, you'll lose a limb. It's stupid. Nobody knows how to do it. But, used judiciously, the word of the day, they can be very effective. So, you can, have a tourniquet on an arm for an hour or two to cut the bleeding down. There's tourniquets people can do with one hand or very effective. I carry one in my car. Run into a wreck and somebody's arm is ripped off. So I think there's increasing use of tourniquets. Another thing that's used more are local hemostatics like quick clot. And these are actually gauze or powders or Band-Aids impregnated with hemostatic substances. That sounds mysterious, but these are like chitin and clays that can directly activate coagulation. So you can stick it or shove it in a wound. You get a lot of local coagulation. It forms a tight band there and shuts down the bleeding. So there are things people can do. And I think it's reasonable if you do any amount of outdoor stuff to carry some quick clot. There's been an effort to actually get more people to carry tourniquets. Like I said, I keep one in my car. There's actually a Stop the Bleed campaign sponsored by the government and the trauma societies to teach civilians how to use tourniquets and these bleeding techniques. But again, just the old-fashioned direct pressure can help in a lot of cases.
For the tourniquet you carry in your car, for instance, can you tell us just briefly what it looks like? And let's say there was a car accident, or let's say descending. You get down there to this poor descending climber, and their arm is ripped off, like, I don't know, just below the elbow, and they're bleeding pretty heavily. How might you apply this tourniquet?
Yeah, so tourniquets should be, above the joint. And, a lot of it's not scientific because you're screaming, the patient's screaming, and you're scared, but it should be applied, where there's an intact arm. And what most of these will have is is a generous strap. If you make it too tight, it's very painful. It can cause tissue damage. And then some sort of windlass where you can actually crank it up. And the issue is, now in this case, if they're squirting arterial blood, when it stops, you hit the arterial pressure. But one thing with a tourniquet ski is you really got to make it tight. If you just compress venous return, but don't take care of arterial return, you actually make the situation worse. So there are rules and stuff. And usually if you get it pretty tight, you can't feel the pulse, the bleeding stops, that's good enough. And these are little kits that actually can be fixed to the arm. Again, the military uses these. They can be done with one hand, so you can do it to yourself. And they're very useful. There's been studies of people kind of making their own tourniquets. And, I guess if you had nothing and you did a belt, make sure you get it pretty tight. It's going to be usually more painful. And again, the part is getting a belt or anything else tight. Sort of that windlass, the twisting motion appears to be key. And, the thing about the commercial devices is, you don't pinch the skin. It's rare to become painful. But I think those, and like I said, a variety of reliable brands recommended by the Wilderness Medical Society, you can buy pretty cheaply on Amazon.
So if you had like a 4-inch strip of like t-shirt, and you put it around the arm and you just take like a stick or something and you twist it around in there, that's kind of what you're talking about? Like something. Yeah,
and that would work. We totally had something else. And people have actually done studies where they've done the strip of shirt, the sticks. If you get it tight, it's very effective. The problem a lot of time with these is you twist the arm, you may twist the skin underneath it. But again, if somebody's going to lose their arm, it's probably a small price to pay.
Right. And those are prospective and randomized, I assume.
Well,
that's right. There are
I think in the military, actually.
The military's actually done a couple small studies to show that these are effective. And then, sad for the animal, there's a lot of animal studies with these. Sure, so some of these, it turns out that actually the tourniquet instant bleeding literature does have randomizations and real trials with it. So it seems like quick clot, the local hemostatics are good. Some of these commercially available tourniquet devices are very good. And again, the problem with the tourniquet is you got to know how to use it. Well, you're trying to read in the dark about how to do it. That's why there's been an emphasis of teaching classes and stuff, or at least watching a YouTube on how to use it. But
maybe we can link to a YouTube video that
I'll see if I can find one
that you approve.
Yes,
maybe the Wilderness Medicine Society has some. So how long can you leave the tourniquet on? I was reading something about like, at less than 2 hours, maybe you can try to take it off and see if the bleeding has stopped. If it has, you can keep it off. But if it's still bleeding, just keep it on and don't worry about like what's happening. But is that just a rule of thumb? Like
that's a rule of thumb. It's going to differ in different people with other tissue damage, necrosis. But again, one thing to think about, obviously you don't want to lose an arm, but if somebody bleeds to death, it's like, hey, their arm looks great at their funeral is not a great thing. But most people would say loosen it in about 2 hours, see if it bleeds. And again, obviously, as we said a million times, try to get the preventive care as fast as possible.
And I never really thought about the fact that you stop venous bleeding but not arterial.
Yeah.
And if they're not bleeding out, obviously, then it can make it worse. So that was a point. Point was taken there. Good point.
Yes.
For this person that's fallen down and has all these injuries, we have antibiotics in our kit that you taught us to pack. I've mostly treated people who already have infections, not people that have like just had wounds. do you wait? Do you try to kind of just clean things the best you can and then decide, like, wait until they show signs of infection before you give an antibiotic? Or would you just give, for a big wound, would you just give like the Amox?
Yeah, most people would advocate, big dirty wounds, just giving a mox and, at least doing something. There's fascinating, again, improvision is big in wilderness medicine. There's fascinating things where people have, rigged up water bottles to squirt through syringes and, do pressure to try to clean out the wounds, to breathe the wounds. So especially if it's going to be a bit delayed getting definitive care, some attempt at wound cleaning, some attempt at antibiotics, just to get a jump on things.
Okay.
And that actually sets up my next question. We've talked a bit about when do you just try to get down the mountain? When do you try to do as much as you can in the field? Like, how do you triage the urgency to stay in place for as long as possible to stabilize the patient versus find the cell phone signal and call for aid?
Yeah, I think if something's really serious, it's probably worth just trying to call for aid. Again, you read a lot of horror stories like, oh, we got trapped and then we went wandering around and they died. So I think a lot of situations, staying put, seeing if you can call for aid, if you got enough people, sending somebody out for help. If it's something minor, like somebody sprained their ankle or, even a busted limb, and you can make a little splint out of some wood and tape and other things, it may be worth hiking out. But, if there is, especially somewhere like the U.S., most places you can get help. The real horror stories are like the guy went, climbing the canyon all by himself, got his arm trapped in a rock and ended up cutting off his arm. So yeah, that no other way to get help. So you do what you got to do. But most places, it's probably reasonable if somebody's badly hurt to wait for definitive care.
I think this has been fantastic. Unless there's any last minute questions, I think we're probably going to have to wrap up here. And this was, for me, this was almost all new territory.
Yeah.
Very much enjoyed hearing about all this stuff. So thank you very much.
Oh, this has been fabulous.
Did you want to give the audience a couple take-home points about wilderness medicine?
Yeah. So number one, it's very interesting, and certainly there's stuff available through the Wilderness Medical Society, and there's actually just wilderness first aid courses if you or your family members want to brush up on it, like the Red Cross does it. Knowles, one of the outdoor organizations, sponsors a wide variety of courses to get into it. I've taken an advanced wilderness life support course, which was a blast. So it's very easy to do. I think, again, to pitch the Wilderness Medical Society, wide variety of educational options there. One thing they're running is actually interviews with some of the masters of wilderness medicine, like Peter Hackett, fireside chats with Peter Hackett, Paul Auerbach. That should be good. Our next meeting's virtual. I'm actually speaking about austere transfusions there. So
wow.
That'll be fun, I think. So I think that's something useful to do. Clean wounds with soap and water. It's what your mother taught you. It's still a valuable thing. And for God's sakes, if you're going to drink and be a young man, stay away from snakes.
This has been another episode of The Curbsiders, bringing you a little knowledge food for your brain hole. Blessed silence. Oh, I thought we could make it through. Get your show notes at thecurbsiders.com/podcast and sign up for our mailing list at thecurbsiders.com/knowledge food to get our weekly show notes in your inbox.
We're committed to providing you with high-value, practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts. It really does help us get new listeners, which we appreciate for our self-esteem, and because we think the show is great. You can send an email to thecurbsiders@gmail.com. A special thanks to our producer for this episode, Avi Yehudit Oglasser, and to our co-producer, Deb Gorth, for help with the show notes. Our social media team is Beth Garbatelli on Twitter, Mad Dog Maddie Morgan on Instagram, and Chris the Chew Man Chew on Facebook. Until next time, I've been Dr. Matthew Frank Watto.
And I've been Dr. Avital Yehudit Oglasser.
And we would be remiss if we did not thank the great Stuart Brigham for composing our theme music that you are hearing, presumably playing behind us, as well as to the amazing Clair Morgan of Not Relief for editing our audio. As always, I remain Dr. Paul Nelson Williams. Thank you and goodbye.
And thanks to our partner, VCU Health Continuing Education, who's helping us offer free CE credits for physicians and other healthcare professionals. Check out curbsiders.vcuhealth.org for more information. If you take TV out of the equation, it really frees up a lot of time.
Yes.
I think there's this author Seth Godin that I like. I think he famously says he doesn't watch TV, and that just frees up so much time that most other people don't have. But I'm just gonna say TV, pretty worth it.
But I'm fascinated by this. But so who? And I know we'll get to the episode. But like, who's just watching TV? Like, what kind of lunatic is just staring glass at? Like, is no one? Are there people that are just doing that and nothing else? Because that just I can't. That doesn't even make sense to me.
No, I just mean like, if you watch TV an hour a day, and if you instead of that you're reading for that hour, then that string that together. That's a lot of extra books and things.
I feel like I can do both. Live your lives, people. That's what I'm saying.